and thank you for coming to this instruction course on unraveling the pediatric eye exam and strabismus. I am Dr. Rohit Saxena, and of course, with me are extremely distinguished speakers and presenters. If possible, I'll request them to come up on the dais. Professor Pradeep Sharma, my co-instructor. He doesn't need, of course, any introduction. He's been my teacher for now close to, I think, 30 plus years. And of course, I continue to look up to him and learn from him, although he has unfortunately now gone on greener pastures after leaving RP Center. Dr. Suma, a very good friend who's at the Shroff Charity Eye Hospital, New Delhi, and doing some outstanding, excellent work there for many years now. Dr. Swati, we'll have to have her present first. She has great amount of work, and not only in pediatric ophthalmology but also in neuro-ophthalmology, and her paper has been shortlisted for the Colonel Rangachari Award. So all the best to her. We hope that she brings the award to us at RP Center. And unfortunately, two of my other co-instructors, Dr. Ankur Sinha and Dr. Digvijay Singh, both of them in different locations, actually, one in Delhi and one in Jaipur, or Gurgaon and Jaipur, landed up being COVID positive, and unfortunately could not be with us, but they have sent their recordings and, of course, their regrets. So we will first start with Dr. Swati, who will be talking about amblyopia changing management paradigms. Dr. Swati, please. नहीं for the photograph. दोनों अलग अलग जगहों पे हुआ है, ऐसा नहीं है. आप कर दो. अच्छा अच्छा ठीक ठीक.
Very good morning to all of you. Now, good afternoon. I thank Professor Rohit Saxena for including me in his IC, and it's always an honor to sit in august company of Professor Pradeep Sharma and Dr. Suma Ganesh. So I would be, as the course progresses, the first topic is, I think, by Dr. Ankur Sinha, sorry, Dr. Digvijay, who would be dealing with the examining of the eyes, but I think he is not there with us. So I would be mainly covering on amblyopia. First. Yeah. So a lot of changes have occurred in our understanding of amblyopia and understanding of its management. Although the basic principle still remains the same, that you need to diagnose it early and treat it when it is possible to reverse it. So the topic is management of amblyopia, what's update we have, and how should we move beyond patches. So as we all know, amblyopia is unilateral or bilateral decrease of vision which occurs as a result of pattern visual deprivation in one eye or in both the eyes, or abnormal binocular interaction between the two eyes, for which no specific cause can be detected, and if treated on time it is reversible. But before that, one must meticulously rule out all organic causes. So as you all know, it can be classified as strabismic amblyopia, and we all know that the esotropia is more commoner cause of amblyopia as compared to exotropia. Amyotropic amblyopia occurs as a bilateral high refractive errors, and anisometropia occurs as a difference between the refractive errors between the two eyes. Vision deprivation amblyopia or a stimulus deprivation amblyopia is because of the congenital causes like corneal opacities, cataracts, ptosis, etc. So management of the amblyopia, early detection, evaluation, intervention on time, and ensures the complete or near complete visual recovery, and also helps in maintaining the binocularity. So there are a number of factors that influence the outcome in amblyopia: age of the patient, how long was the amblyopia, when was it treated, amount of refractive error, and also the type of amblyopia, because generally an isometropic amblyopia, strabismic amblyopia are more amiable to treatment as compared to the stimulus deprivation amblyopia. And of course, the most important factor in the recovery of amblyopia is patient compliance. So as I said, identify the cause of loss of vision, correct the refractive errors adequately. Preferential stimulation of the amblyopic eye still remains the line of therapy in such cases. So the goal is to achieve the equal vision in both eye. That was the goal earlier, but now we have that the idea is to achieve a binocularity also. Just achieving equal vision in both eyes may not be enough. So optical correction, occlusion therapy, penalization, active vision therapy, pharmacotherapy all have been there since ages and have been used in one or the other form in the cases of amblyopia depending on the degree and type. But what has recently happened that the active vision therapy is gaining more and more role along with the patching, along with the occlusion to overcome this problem. So optical correction still remains the first and the foremost way of treatment of amblyopia. Why? Because a proper, sharp, focused, sharply formed image is the best stimulus an eye can get to improve the vision. So age appropriate, proper refraction and proper prescription of lenses is the most important intervention, and it's the only intervention in cases of ametropic amblyopia and to certain extent in anisometropic amblyopia, because certain patients, around 20% of patients of anisometropic amblyopia may show improvement with the correction alone. So these are the national consensus guideline published in IGO last year, or maybe last year. So these are the cutoff levels when you want to prescribe glasses in the different types of refractive error at the different age groups. So one has to keep in mind these cutoff errors, because if we wait for prescription for the longer period, the chances of amblyopia being more dense is more high. So coming to occlusion therapy, it still remains the gold standard. There is no competition to it, and success tends to decrease with the advancing age of eye. Well, what was once used to be a total occlusion, now as pedic studies have shown, many of us have shifted to part-time occlusion. So studies have shown that the 6 hours occlusion is as good as a full-time occlusion in moderate cases of amblyopia, while a 4 to 2 hours of occlusion may be as good as 6 hours occlusion in a mild case of amblyopia. So many of us have shifted to part-time occlusion, but one has to remember that with full-time occlusion, the speed of recovery is much more better. So occlusion therapy, it's not just enough to give occlusion therapy, you have to maintain it, and you have to maintain it till the vision of the patient stabilizes on 2 consecutive follow-up visits, which are 2 months apart to each other. And when you want to stop it at the end of the day, you don't have to abruptly stop it, you have to slowly taper. Taper means if you are giving a full-time occlusion, please shift patients to part-time 6 hours occlusion or a weekend occlusion, then shift them to a 2 hours occlusion or alternate day or whatever is convenient for the patient. And not to the important thing is not to stop it abruptly, because if you stop it abruptly, the chances of recurrence are very high, as high as around 70%. And in a study done from our center, we have seen that around 13% of cases will show some recurrence. The factors which are majorly responsible for weakness for recurrence are older age or the onset of the treatment, larger visual recovery. So more is the recovery, more are the chances of recurrence. Better visual acuity recovery after the therapy, younger age at the time of the stopping the occlusion therapy. So it's important that we continue the occlusion till the age of plasticity is over. Then penalization, so optical penalization can be done with overcorrecting glasses, but then again it may not be so useful to do it in severe amblyopia, only in mild to moderate amblyopia, where you can give the amblyopic eye an advantage over the non-amblyoptic eye. Both optical penalization and pharmacological penalization can be tried. Pharmacotherapy, drugs such as levodopa, citicoline, both have been tried, and they have shown very short-term effect. So what is coming up more, prominently is active vision therapy, where you have to give children some kind of active task. It has been there since ages, but now it can be done in form of video games, which are much more acceptable child, and it's a fun for a child. So that's why it's coming up. So these allow for the interaction of the both eyes, and also kind of treat or make the visual system relearn the entire interaction. So we have this study published from our centers where monocular video games were compared with the occlusion of, and we found that the patient who have had monocular video games, active vision therapy with those games, had a better visual recovery at 3 months. The role of dioptics, its advantage over the monocular video games is that it allows binocular interaction and thus maintains the binocularity. So two eyes are presented with the same stimulus, but one eye, a sound eye, is presented with the stimulus which is much more lower in contrast, so that the poorer eye has an advantage. And we have a study in this group also where we compared the 30 children with dioptic therapy and 30 with part-time occlusion, and we found that although there was a the base sorry the final visual acuity at the end of 3 months improved in both the cases similarly, and the final visual outcome was same. The near stereo acuity in the game group had better improvement as compared to the occlusion group. The contrast was also better. However, the interesting finding was the children who were less than 10 years were not so compatible, were not so happy with the video game as compared to the children who were more than 10 years of age. So to conclude amblyopia, it's important to rule out the cause, and at the time there is no there can never be an overemphasis in the proper refractive correction. There can be never an overemphasis in the proper optical correction, prescription of glasses. Discuss the type of amblyopia, continue the use of glasses, continue the use of occlusion, and maintenance therapy with gradual taper is important. Thank you.
Thank you, Dr. Swati, for an excellent overview of amblyopia and the recent advances in management. And truly, amblyopia therapy is now becoming extremely exciting. A lot of interest is there in the management and getting visual therapy, including for adults. So a lot of work is going on that, and thank you. Maybe we'll hold on to our questions and we'll try and discuss them in the end. We will have the presentation of Dr. Digvijay Singh, who his talk was tips
for an effective eye exam and refraction in children.
could you project the slides, please? So Dr. Digvijay himself has given the topic of his talk before I could. So yes. Next.
Tips for an effective eye exam and refraction in children. Taking a good history is always a challenge in children because you could have limited interaction with the child, or family history may sometimes be difficult to elicit, as other siblings may appear normal in contrast to the index case, the parents. You should always try to examine the other siblings. Treatment history again is difficult to get because the actual person providing the treatment may be different from the informant, so ask for records. Also, parents may often misreport compliance, particularly, for example, with the patching therapy. Let us move on to examination. The most challenging part of a pediatric eye examination is the refraction. One has to be patient. The retinoscopy is our best friend here. You could use portable autorefractors or photorefractors, but they have their errors. The appropriate cyclopegia is important, such as atropine or cyclopentolate in the smaller children, particularly children who have got esotropia, and you can use hometropine in slightly older children. Look for the head posture or external adnexa at a time when the child is not conscious, maybe typically when he's just walking into the room. For evaluating the ocular alignment or the ocular movements, the best way to look for a cataract or any lenticular opacity is a distant direct ophthalmoscopy. The fundus evaluation in children is made easier with an indirect ophthalmoscope. An examination under anesthesia may be needed to screen the periphery. Specially prepared diluting drops may be used in very small children. The intraocular pressure measurement in children is often not needed, but if it is, you could use the non-contact tonometry, or you can do a Perkins tonometer, but an easy one these days is to use the tonopen or the eye care tonometer. Special tests such as stereoacuity can be done using the two-pencil test or using land stereoacuity or the Frisbee-Davis distance 2. All these tests are easy for a child to understand, comprehend and respond to. Thank you for your patient listening.
So, thanks, of course, to Digvijay that he presented. Of course, it finished a wee bit early, so if there are any points, one or two, which we could make or any queries that you would have. He raised the point of dilatation. So, the key importance to remember that in all cases of esotropia, particularly even in young children and even teenagers, especially if they are recent onset, the first refraction must be under atropine. However inconvenient it may appear, the first refraction should be under atropine. Ointment is preferred, especially in young children. In older children, you could consider drops, but because of they may be messy, but ointment in younger children because the risk of excessive dosing, and of course the longer stay in the eye, by which you can actually have a sustained effect of the atropine. So we advise 3 times a day for 3 days for the baseline first refraction. So any refraction, first line refraction, one would advise, in fact, in a younger child up to 7 to 8 years, the first refraction, irrespective, should be under atropine, but definitely for esotropes, and of course esotropes any age. We generally do not prefer cyclopentolate because of their definitely reported neurological signs, and just in case if you are considering, it may be important that you keep the child under observation for a little while in your OPD, because the children are known to have neurological side effects or behavioral abnormalities which can be very disturbing for the parent, because he's come for an eye exam and finding the child behaving unusually may be an issue. So that those are very, very important things. Dr. Digvijay has listed out all the things that can be done in the first eye exam, but all, of course, are not necessary. The important thing is to remember that the first, and that's what, something I follow in my clinic, that the first exam should be an extremely happy one for the child. So do not struggle to get his vision. If possible, prefer not to dilate unless it's it's urgent or they cannot come back. My usual routine would be that the first eye exam would be a general exam, understand the complaints, try and reassure the patient, and give them a plan of what I am wanting to do in the subsequent visits. Whenever I need, or if I, and more often than not, you would need a dilated exam, especially for refraction. Uh, to put the blame on those bad eye drops, I ask the parents to put the drops, and of course, if it's an atropine, ointment at home, so that the child does not associate the unpleasant experience of the dilating drops with me. And of course, the parents put it when the child comes next time, we plan for the refraction. So, like I said, first time, try to make it a pleasant experience. Most children are, think of doctors as pediatricians and remember doctors as those vaccinators who keep poking needles or drawing blood. So we don't want that impression, and we don't want non-cooperation, especially taking vision. And again, one thing you should remember, it's not necessary the vision may be subnormal. The children will read a few lines and then just sit down and relax and think that, my job is done. So you may actually have to coax or maybe do a couple of repeat exams, visual assessments to test for the real vision. So we'll probably go on to the next talk by Dr. Suma and maybe keep coming back and forth as we'll see how specific tests or specific examination techniques are there in each and every specific disorder of pediatric ophthalmology that we see. So Dr. Suma would be talking to us about approach to a child with esotropia.
Um, Respected chairpersons and my dear friends, I would be speaking on a topic approach to a child with esotropia. So any child presenting with esotropia, we need to know the age of onset, whether it is intermittent or constant, or whether it's more when focusing for near. So these are the important history points we need to take. Like this 4-year-old boy coming to you with inward deviation of left eye since 2 years of age. There's a normal birth history. So you find that the vision acuity is 6.9 in the right eye and 6.18. And the prism which we made, the deviation which we measured is 30 prisms distance and near. So we need to do, as Dr. Rohit already mentioned, it was very important to do it with atropine eye ointment, because I find that even if you do it cyclopentolate, you're not sure whether you have corrected the hyperopia completely, and also the child may have side effects with cyclopentolate. But if it is really needed, like if the patient is from outstation, cyclopentolate can be used. You put it at an interval of 15 minutes 3 times, and then you re-examine it after 1 hour. So full cycloplegic, so now the refraction what we got was +4 and a +5. So now you can see that there's a difference of 1 diopter, and this is the reason why the child has an amblyopia in the left eye, also could be one of the reasons. Okay, so this is why we have to remember what Dr. Swati said, that we need to look for the difference in the anisometropia also, and that is a cause of amblyopia. So even after the squint is corrected, so we need to give so you repeat the vision after 2 months. If you find the vision has not improved, we need to continue with the patching therapy. So what the parents ask normally is what happens, these are routine questions which every parent asks, because the moment you say that the child has a squint, has esotropia, the parents ask, now what happens to the number, whether will my child have to wear the glasses lifelong? When are you going to wean off? Will my child want to wean off the glasses? So what we can guide them is that up to 6 to 8 years of age, we need to make the strabismus perfect. So then our child needs to wear the glasses, and the child's number may increase, because you have to tell the parent that it may increase. The moment you say that the number has increased in the next visit after 1 year, they'll jump and they'll say that, okay, how did the number increase? So you tell them the natural course. The natural course is that the hyperopia can increase, and what we are aiming of is that we do not want the child to develop a partially accommodative esotropia with the glasses. So tell them, you need to make the child wear the glasses all the time. The glasses number may increase till the age of 6 to 8 years. That is a natural course. After 8 years, we may think of weaning off the glasses, 0.5 or 0.75 per visit or per 6 months, if we find that this deviation is being maintained properly. So if you give this to the counseling to the parent, I think they accept the treatment. And at least I do not reduce the weaning off, though the American literature says at 7 years of age. I do not do it before 8 years of age, because I find that again, if the esotropia keeps coming in, then again which you have nicely maintained, you again have to start amblyopia treatment. So lower levels of baseline. Suppose the child has started with 3 diopters. For the literature also says that we can wean them off. What we find that after say 2 diopters of hyperopia, weans off in another, say after 8 years of age, up to 12 to 13 years of age, up to 2 diopters may wean off. So if the child has already a low hyperopia, then there are chances of weaning off. So you have to tell the parents, if it's already a high hyperopia, the chances of the child wearing glasses is going to be there. They may have to continue to wear glasses. So they have a very good binocular potential. Now suppose if the distance and near there is a disparity. So if you find that the distance and near it is more than 15 diopters, it is same, then it is called as a partially accommodative esotropia. And in these cases, you need to do surgery. But if there's a near and distant disparity of more than 10, what we need to measure is 2 things, the AC by ratio and the NPA. So now how do you measure the AC by ratio is doing a simple test. This is called as the gradient method and the entrophoria method. We use the gradient method where you measure it deviation with the lens minus the original deviation, and you divide it by the 3. So this is how you measure. Now suppose if you had a original deviation of 30, and with the near deviation you get a 10, then you divide it like 20 divided by 3, and that's how you get 6.6, which is a high AC by ratio. So then you need, in these cases, we know that the normal range of high AC by ratio is between 3 and 5, so you need to give bifocal glasses. So these bifocal glasses, you can do not start with +3 immediately, you can even start with +2, because what I've seen that many people go straight to +3. You see, even if it +2, if it is making orthophoria, it is better to put the minimal plus which you get orthophoria. It should bisect the pupillary margin. Now this is something, and now the problem is these executive glasses are not made routinely in most of the optical shops. This is a problem which we face practically. So they always ask, can we use a D-shaped cryptocle? So some older children, yes, but we should insist on getting these executive bifocals being made if from any optical shop, I think whoever does this, because the D-shaped, I do not find they still, why are we giving them? Because the near should have fusion. Otherwise, if the near is not corrected, the child will again land up with suppression. So you may have distance fusion for the squint, but you will have still suppression for the near. And this is how children will then decompensate into partially accommodative esotropia. So if once you have a partially accommodative esotropia, the treatment is surgery. Now the most important, most of the time, recently I had a patient who was like, was telling me that after surgery, she nearly had an argument with me that even though I had counseled her that the glasses will be removed, will not remove after surgery, she said even after the surgery, I see the squint without the glasses. So it is important to counsel them that we are treating the surgery only for the squint with the glasses and not without the glasses. Because parents normally, like, I thought she would really sue me this time, the way she was like after me and saying that the squint is still there without the glasses, you know. And I think now I have decided after that I will be taking a verbal consent, that because the patient was really after me like it was, you know. So I will take a verbal consent from the patient and say that the child has to wear glasses after surgery and we're only correcting the squint with the surgery. So be careful when you're doing partially accommodative. Most of the parents think that we're going to remove the glasses. So this is very important to tell them that even after the surgery, the patient has to wear glasses. So in a normal AC by ratio, if you have a convergence excess, where there is a distance and near disparity, and it's not corrected with bifocal, like if you put a +3 with the gradient method, you do not get a high AC by ratio, then we need to do a Farden surgery, which is 12, you put the posterior fixation suture at 12 to 13 millimeter from the insertion. You use a non-absorbable suture, and you place the sutures in the sclera, and this gives you a good effect. It's suppose if you have a 30 and a 50 for near, so you would do the 30 recession. So you will do a recession for the medial rectus recession, and remember that Farden gives you a big large effect. So when you're doing the recession, don't do recession for a normal like you're going to do like a 5 and 5 for a 30, because Farden itself gives you a large effect. So maybe you would do around a 3 or a 4 millimeter medial rectus recession along with the Farden. The other one is a non-accommodative esotropia, which we get is a infantile esotropia. In this, basically, the only difference what we should know is the to do a doll's eye head maneuver to rule out whether it's a Duane's or whether it's a sixth nerve palsy. So because they will show an abduction deficit, but it's mainly because of the what they have is an abduction limitation, which is seen when they cross fixate. So important thing in this, we need to correct the refractive error. Okay, please, before we go for the surgery, we need to do atropine refraction. See if it is more than 1.5. So even with 1.5, I would still give a trial of glasses before going for surgery. And if there's a dominant eye, you still patch. And we need to do early surgery. Now, early surgery means it's not necessary till you get good measurements. It's not that you just go and operate. So at least get 2 to 3 measurements before operating them. And you measure it mainly from the limbus. These are, the results are good, but the problem is the follow-up. So you need to follow them up. Then we have an acute committed esotropia, which is, do I have time or?
A couple of minutes if you can, so that.
Because, so this is now, we have seen in this COVID times, lot number of cases presenting with acute esotropia. So we have 4 types. The type 1 is a Swan type, type 2 and type 3. But these are types which give you good results. In fact, I find them the good binocular because they have diplopia, and so they give you the good results. But now this is a child who presented with acute onset of inward deviation of eyes, came with a large angle deviation. It was variable. Remember this, it was variable. When we did the, sometimes I was getting 35 when you do a dynamic retinoscopy, and then when you do, you get a lead. So that means to neutralize it, when you do a with the width movement, you need a -4 or a -3 too. So that means this is a pseudomyopia. So in these cases, it is important to do an atropine refraction, and these are cases of accommodative spasm or spasm of near reflex. So you need to treat them with atropine, bifocal glasses for I've written here for a month. In some patients, you need to do the treatment up to 3 to 4 months. And then with binocular vision therapy, where they give relaxing exercises, we have made the child orthophoric. So rest I will not cover. These are the Duane's and the other esotropias. But I think we should more focus on, and I would again like to say, please, in all children with esotropia, please do atropine refraction and give the full prescribed glasses, because I still find many children still coming to me with not the full prescription of atropine glasses. Thank you.
Thank you, Dr. Suma. Thank you very much. Excellently covered. Can we have Dr. Ankur Sinha's presentation? A very important point about the glasses. In fact, many parents have come back after in accommodative esotropia. The initial presentation of the accommodative esotropia may be intermittent to start off with because the child is not concentrating all the time. But once you have given the glasses, and then the parent will come back on a follow-up and say, now almost always when the child removes the glass, the esotropia is present. The reason is that the child has now started seeing clearly all the time almost. So when the glasses are removed, the child continues to desire to see clearly and therefore accommodates. So in fact, parents get a little disturbed that earlier it was occasional, now it's always without glasses. So you have to again go back and reinforce that with glasses it's not there, and that's the key thing. And sometimes you will see that there may be for a few days, there may be a slight residual esotropia which may be small. Don't jump in for surgery. It may take a little time for that to actually level off with your refractive error correction, or else you may require to go in, do a repeat refraction. So if there is a small residual esotropia, it may still be that there may be an undercorrected hyperopia that may need to go in and do it again. So the next talk is by Dr. Ankur Sinha, who sent a Zoom presentation which is on management of a case of intermittent exotropia.
A very good afternoon to each and everyone. I would like to thank Professor Rohit Saxena and office bearers of AIOS for giving us this opportunity. And I will be here to talk about managing the case of intermittent exotropia. Now, intermittent exotropias are one of the most common forms of strabismus seen. They develop because of defective development or inheritance of binocular single vision or abnormal action of medial rectus. It is important to rule out pseudoexotropia, fundal collobomas, and macular drags. Now, there are a lot of problems in IDS or intermittent exotropia. Jampolsky said that exophoria progresses to intermittent exotropia and then to constant exotropia. The binocular single vision is present in cases of intermittent exotropia, but strabismus may be compromised. There could be symptoms of asthenopia, diplopia phobia, or there could be cosmetic and psychological issues. Now, most patients of exophoria progress to intermittent exotropia, then to constant exotropia, but some of them may remain constant. The distance stereo acuity drops much before the near and may not recover fully. There could be problems of headache, eye pain, blurring of vision, micropsia, presenting as asthenopia. The bright light dazzles the retina, disrupts the fusion, causes diplopia, and causes closure of one eye, which is called as diplopia phobia. There can be cosmetic problems, but the squint may be seen in pictures and it will be more obvious in situations of physical stress and tiredness. There could be psychological issues where the patient is not able to face others and there may be a feeling of inferiority. Tuani classified the intermittent exotropia into basic convergence insufficiency, divergence axis, and simulated or pseudo-divergence axis, depending upon the variation in distance and near deviation. Burian then modified this classification. Burian used the difference of 10 prism diopters as compared to 15 prism diopters used by Duanes. And then Kushner used the term tenacious proximal fusion, which is acting for near. Now, this table compares the various classifications. Basic when distance is equal to near. Convergence insufficiency when near is more than distance, and it could be caused by a low AC by A ratio or fusional convergence is low. Divergence axis where distance is more than near, the distance deviation is more than near, which is called as true divergence axis. And similar divergence axis will have distance equal to near, but there could be a tenacious proximal fusion or high AC by A ratio, which is playing a role in these cases. Then Carhouse described the various phases. If there is exophoria for distance and near orthophoria, the patients are usually asymptomatic and the patient usually undergo undetected. If there is intermittent exotropia for distance and ortho or exophoria for near, the patients may be symptomatic for distance and may need treatment. If there are exotropia for distance and intermittent exotropia or exophoria for near, the binocular single vision and may be compromised. There may be a suppression of scotoma for distance. Again, these patients would need treatment. And in stage 4, there is exotropia for distance as well as near, and such patients lack binocular single vision and they are late for treatment usually. Approach to a patient of intermittent exotropia begins with comprehensive eye examination. If there is amblyopia, look for evaluation and assess associated features, perform post-patch PBCV, and also try and do a post-op diplopia test if there is a chance of having diplopia post-surgically. Now, when to operate this patient is a question. So it can be a subjective decision depending upon the worsening of control when the patient is progressing from Kalhoun stage 2 to stage 3, falling or low stereo acuity, when the intermittent exotropia is presented more than 50% of waking hours, or there is presence of diplopia phobia. To make this decision more objective, a new Carlson score was introduced where the patient was assessed in the, at the home and in the clinic for distance and near based upon the type of refixation and control over the blink and the frequency of breaking. The Newcastle score was given. A Newcastle score of less than 2, it suggests that the patient is well controlled and there is high probability of a stable course. If the Newcastle score is between 3 to 6, the control is moderate and we have to think in terms of surgery. If the Newcastle score is 7, the control is poor, and this gives an indication that despite the surgical correction, the recovery of binocular vision strabismus may still be poor. Now then there can be certain non-surgical managements like convergence exercises. They do not tend to cure or change the basic deviation. They convert the tropia to phobia. And the appreciation of physiological diplopia is a must when we advise these kind of exercises. Overcorrection of myopia works only in cases with high AC by A ratio. Prisms can also be given, but they tend to undercorrect deviation. Now, this is a young girl having a normal stereo acuity and good control of IDS with glasses. So she can be given these glasses which are slightly overcorrected and the patient controls the exotropia well. The choice of surgery depends upon the distance versus near deviation, AC by A ratio, and lateral gaze concomitance. There could be problems in accurate measurement because the apparent control of deviation may vary at the time of examination, and at some other times it is usually affected by the fusional control, the alertness, the state of health, and convergence accommodation relationship. In younger children, there is a lot of limitation because we may find it difficult to have a good assessment. It may be difficult to find out the other movement abnormalities, and then there are chances of amblyopia if we inadvertently overcorrect the strabismus. For older children, we can always plan to slightly overcorrect by 5 to 10% diopters. For basic type of intermittent exotropias, you can plan RNR or bilateral lateral rectus recessions. For convergence insufficiency type, you can plan MR resection. And for divergence excess, we can plan lateral rectus recessions. Large LR recessions should be avoided because they can give rise to lateral gaze concomitance. Now, this is a case of intermittent divergent squint where we can see there's an inferior oblique overaction and the patient needs to be operated for the same also. This is another case where we can see there is a poor control for distance, and even if the patient is trying to strain for near, she is not able to control the strabismus. This is the time for surgery for this patient. Another case where there is intermittent divergent squint which associated DVD. So we can see here is the patient is eye is covered with Spielman's. The eye goes up and out absolutely. The left eye goes up and out, and then as they cover the right eye also goes up and out. So the patient undergoes right superior rectus recession by 7 millimeters, left superior rectus recession by 10 millimeters, and left lateral rectus recession by 5 millimeters. And this is 7-week post-surgery, and this is the post-surgery DVD. We can see the DVD is still there, but it is reduced to a very great extent. Another girl with poor control and 240 seconds of arc on TNO, she also needs a surgery. In the end, I just want to say a good case-based assessment is mandatory for successful outcome. Thank you.
Thank you, Dr. Ankur, for the presentation. A few things, of course, are important when you're managing an intermittent divergent squint. When we are operating or planning for an IDS, in a younger child, we tend not to overcorrect. We would prefer to have an optimal correction because we cannot afford an overcorrection and a consecutive esotropia, which can be more amblyopogenic. The second thing is then older patients, beyond the amblyopic age group, we would be happier with a slight overcorrection to catch the slight exodrift that happens over time. So that's an important thing when we are planning. In a very small child presenting with early breaking of intermittent exotropias, look for reasons why the child is breaking. More often than not, there is going to be either oblique overactions, or there is going to be a subnormal vision which is responsible for the child breaking. Otherwise, mild moderate exophorias children, because they are inherently mildly hyperopic, are able to control. The other thing that was being pointed out, that in intermittent divergent squints, refractive error correction is very important, because we are going to improve the fusion which is going to control. Even the exercises that we are giving are actually wrongly talked as convergence exercises, or they are improving convergence. They are actually improving or giving an attention to fusion also. So because it's finally the fusional vergence mechanism that is keeping all of us, and most of us, especially in this elite group, would be myopes, and all of us have fair amount of exophoria. So this exophoria is well controlled by fusion. So in an attempt to improve the fusional vergences, you would be able to control. So I'll talk about surgical planning now in strabismus, and some of it may actually overlap with what has been discussed. So here goes. It's unfortunately not moving. Yeah. So before we start our surgery, it's important to note, because looks sometimes can be deceptive. We've talked about accommodative esotropias. Please remember a baseline, it can never be overemphasized. A baseline age-appropriate cycloplegic refraction is a must before any planning for surgery. We talked that divergent squints also need a refraction. You need to make sure that you give the best corrected visual acuity, and then evaluate for the frequency and the magnitude of the strabismus. Overcorrected, over minus classes has been talked about, but recent report has come which has said that they do not significantly help in the long-term control in these patients. Obviously, check and manage for amblyopia. It is essential before you think of any surgical intervention. Acquired squints, and always go back and check for acquired. Sometimes the patients relate to a recent onset squint, or reported as a recent onset squint, because of a certain event that happened. So a small injury or fall from the bed, and the parents start noticing that there is a strabismus, which probably was pre-existing. So you need to go back and look at photographs. So orbital lesions also can present. So if you are in doubt, you need to image. You need to make sure what you're looking at. So a recent onset Brown syndrome girl presented to us. You can see a cysticercosis in the superior oblique tendon, which was responsible for the recent onset strabismus. Always ask and beware of variability, particularly if you feel that the squint is not early onset. And one dictum that we always follow is that if you cannot understand the type of strabismus, it's not localizing onto any lesion or any reason, think of myasthenia. Myasthenia can mimic anything, and when in doubt, work up for myasthenia. Be sure of your diagnosis whenever you are planning. Orbital and adnexal, all lesions, all appearances must be looked at. Do not mistake a sixth nerve and advance. Always be careful in what your decision making is. Very often, your OPD would be flooded with pseudo-esotropias. Look at the central corneal reflexes. You can see that from afar the child looks as if the child has esotropia, but you look at the Hirschberg reflex, you look at the test and see that the corneal light reflexes are well centered. This is a very, very common reflex. Again, please remember that a child who's apparently pseudo-esotropic in your OPD may still have an intermittent esotropia, probably accommodative. So do not just go what you were seeing, repeat, follow. Also, there's nothing to preclude a now pseudo-esotropia from developing a true esotropia over a bit of time. So again, keep these children follow up. Tell the parents why you feel this is a pseudo-esotropia, so that they understand if there is any change. Factors that affect decision making would be angle kappa. Basically, we talked about pseudo-exos, pseudo-esos, the adnexal relationships, the epicanthal folds, the hypertelorism that can give an apparent amount of strabismus. So one, it is important to identify them, whether there is strabismus or not, and two, what is your endpoint of strabismus, because you do not want to operate or correct more than what the true strabismus is, just because it appears to be there, and epicanthal folds and all will go away with time. Look for limitation of movements. A version must be followed by adduction, so that you are able to know whether there is a true underaction of a muscle, or it's just because the other eye, the fixing eye, and this eye is just not moving that much. So there is no true limitation actually. Intraoperative FDT is a must, which must be freed. The sensory state. Sometimes in non-functional eyes, exotropes, we may want to overcorrect again because of the exodrift that can happen. What are your outcomes, whether it's a functional or a cosmetic outcome? And of course, look for oblique actions. You have a lot of weakening procedures that are there. The most common for the recti would be graded recessions, and of course, very rarely we do a FARDN that was mentioned by Dr. Suma. Know the limits that are there. Less than the minimum amount of surgery would be ineffective. If you do more, you're going beyond the arc of contact, and the muscle will show significant underaction and limitation of movement. That's extremely important to note, because you do not want limitation of movement in the post-op period. Excessive recessions can cause palpable aperture changes. Especially if you're operating the vertical recti, you're going to have lid-related changes, underaction of muscle actions, and reduced saccadic velocities. Strengthening procedures, the most common is the resection or the plication, rarely advancement in a previously operated eye, and of course, tucking or double breasting for superior obliques. If there is very poor function in a muscle, you may need to augment it by doing up transposition procedures. Again, there are minimum and maximum for resections. The maximum limits for resections are very important, because after a particular length, you are actually going and removing myofibrils, which is also in itself a weakening procedure. So you do not want to go beyond that. If at all you want to do more, you can probably do a bit of plication so that you do not actually lose muscles. There are a lot of gross nomograms that are available that can assist your planning, but over time you may need to actually adapt and adjust a little to your surgical outcomes. The variability is on a variability in outcomes based on even standard nomograms in your hand is the variability of the surgical procedure. So fortunately or otherwise, our surgeries have a lot of inherent variability on the surgeon's hand. Uh, 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 we talked about bilateral recessions versus unilateral recess-resect. As of now, there is no evidence that anything does better. Of course, in local anesthesia, we would prefer to do a unilateral eye surgery because we don't want to block both the eyes. But generally, it is better to divide the surgery between the two eyes, especially in children. And of course, if you have to operate the other eye because obliques are there in both the eyes, you may want to spread the surgery in both the eyes. Important in decision, recessions are stronger than resections. The response of the medial rectus is more than the lateral rectus, is almost in a ratio of 3:2. So there is a graded effect of each muscle surgery based on the amount per amount that you are doing. You get 25% more effect if you operate one eye, and you get 25% more effect in infants. So accordingly adjust your planning. It's important that you must be aware how much impact or effect you're going to get for every that you are going to do. Do not do excessive amount in one eye. Always try and divide. Do not induce incompetence. Divide, if possible, the surgery between the two eyes, because there can be palpable fissure changes. The patient forgets that he had a large squint earlier, and post-op keeps coming back and saying, my eye looks smaller. Other factors include the age, more effect in younger people, patient's response, it may be a little variable. The other things are the larger deviations, more the response. So the amount of effect that you're getting from increasing your amount of recession from say 3 to 4 versus 5 to 6 or 6 to 7 is totally different. Is much more if you in larger deviations. And of course the sensory state and what is your final planning. The other most important factor affecting outcomes of surgery is your planning. How are you placing the surgery? How do you handle the tissue? How much dissection you do? So always be consistent where you're holding the muscle from, where exactly you are marking. So you always hold the muscle when you're marking on the sclera from the center so that you do not distort the insertion. Take it from the lateral edges and try to be as perpendicular as possible. This length and oblique lengths are totally different. So please be perpendicular to the limbus. That's very, very important. Pass it where you've passed the mark, because otherwise even a millimeter anterior posteriorly makes a difference. No difference essentially whether you use a limbal incision or fornix. Fornix are technically a little more demanding, cosmetically and early rehab better, but no outcome differences. These of course are decisions based on what is your final endpoint. Always look for A and B patterns. Do not miss them, because they are an important, if missed and not operated, they are an important cause of recurrence of surgery. So oblique overaction, presence of A and B pattern, Presence of oblique along with the NV pattern must operate the obliques along with the horizontal recti. If there are no obliques but a pattern is present, you may need to shift the horizontal recti accordingly based on the pattern that is there. So just to show you the inferior oblique overaction in this patient along with the V pattern that is there. So identify the oblique overaction, operate for that. A patient without a presence of a V, without significant oblique overaction, you may need to do the shifting of the horizontal recti. Botox is an intervention that can be done in patients presenting with paralytic strabismus early and can bring about early rehabilitation. Again, importance of eye movements, you must need to know, like in this case of a orbitotomy with lateral rectus palsy partially recovered, you could get away with a large RNR procedure, but in this case you can see there was significant abduction deficit. You require a transposition procedure because the muscles did not have power. So these are important things. One must know that things can be confusing, but a good workup, correct diagnosis and realistic expectations are essential for workup. Thank you. I would now request Professor Pradeep Sharma to present his talk. He's going to be talking to us on workup of paralytic strabismus.
Thank you, Dr. Rohit. It's been a wonderful session going on, and I'm sure it's coming. Yeah. So in children, I mean, we are more and more focusing that strabismus should be treated in childhood, and we are not talking of early surgery, but early alignment. So be careful. It's not just we have to jump to do a surgery, but we need to ensure that alignment comes in early. And this is what can be the story of each and every child, which is basically of Kenneth Wright's son, who himself has put up in his book that this child was detected to have an esotropia around 3 months, given full correction, and still had a non-accommodative esotropia, which was operated. So what we need to do in children, because we may not be able to do all the tests, we have to have a simple recipe, that is OCIPE. Observe, confirm, infer, plan, and execute. Head postures is one of the things which you should not miss. The moment the child comes in your room, notice the head posture. It may be because of paralytic squint, it may be because of a nystagmus having a null position. Notice that. Is there a face turn, a chin down and up, or a head tilt to right or left side? In an infant, when you're looking, then you can use your ophthalmoscope at 1 meter distance. Look for the Bruckner's reflex. Shine the light on both the eyes with your ophthalmoscopic aperture, and you'll see that one of the thing is much more bright. So the red reflex is not only telling you about media opacities, but it also gives you that there may be an esotropia or even high refractive errors, as we can see in the photo screeners are based on that principle. Fixation preference is another simple thing which will help you know that the child is having an amblyopia. If you see a child having a squint, just cover the eye which is squinting, no response. He is not much interested in that. But the moment you cover the good eye, he will revolt. He will not let you cover because he is being actively blindfolded. Again, notice if he is having a fixation preference test. I mean, this child you see in the one side, he is using, now we have to be careful which eye is using. The moment you cover the right eye, you will see that he immediately shifts his face turn in order to see from the left eye, because he has an adduction preference. Now these are, it may be a Sciancia syndrome, or it may be a case in which there is a nystagmus with adduction null. So these are to be picked up. Pseudostrabismus, I think earlier has been talked about. Be aware of it. It can be because of the telecanthus, or it may be because of larger palpebral apertures, uriblephron. I mean, these are the cases which even I was for a moment befooled, that I thought it's an esotropia, but the moment I did a cover test, I know that it is wrong. Similarly, you may have pseudo-exotropias in the bottom picture, which shows you that there may be a thing which will be revealed by a simple cover test, your thumb rule. You just need to put over one of the eyes and you'll see that the eye has not moved. So cover test is not difficult to do in a child if you are just allowing. Many of the children, by the way, will not let your hand come close to their head. So you have to be careful. You have to approach from below. Glasses, Dr. Suma already mentioned that you need to be giving full correction and also looking for any convergence excess. For screening vision, we have this tool which has been given by American Academy of Ophthalmology, so which is there that we can follow this even objectively. But if you want to do an age appropriate vision test, so this is the chart that we usually would like to recommend that can be used. But binocular testing, a child just 3 plus would be able to tell you about the binocular testing on Bagolini. You just ask, play with him that, okay, do you see any line? And he will draw it and he'll say, okay, this is one line or it's a cross. And once there is a cross and the eyes appear to be, let's say, ESO, but not giving a cross response, you are sure that either he is having an esophoria or he is having an HARC, harmonious ARC with the manifest esotropia of small angle. This is a very simple test which I keep on talking about, the modified Lang's 2 pencil test. You just need to play with the child. Give a pencil in the hand and you have the pencil. Now you just see that a child having an esotropia which is manifest will never complete this test correctly. So this is, even I use it post-op. After my surgery, I just play with it and I know, okay, it's got corrected. So even if you're not able to measure, stereopsis is the final goal and that is what you need to pick up. Assessing stereo acuity, you may have the charts, but I would recommend anybody doing serious strabismus practice should have at least a near vision, near stereopsis chart, and the one I prefer is TNO, red glasses based. As Dr. Rohit mentioned, look for A and V patterns. This child appeared to have an ortho in primary position, but the moment she looks up, there is an exo, and the moment she looks down, there is an esotropia. This is a pure V pattern. And if you pick it up correctly, you do the inferior oblique surgeries, you can straighten the eyes in all the gazes. Now, dysmotility in particular, it may be neurogenic, third, fourth, sixth nerve, INO, anything can which affects adults can also affect children. So you need to be following the same things that we are talking about, but more specifically look for these conditions. It may be a Duane's retraction syndrome, a Mobius in the central, you will see, or it may be a congenital fibrosis of extraocular muscles. Always look for fields and fundus in paralytic strabismus. Never forget this. You may be able to pick up these cases. A lateral rectus palsy will be picked up like this girl comes in with a face turn, and the moment you ask her to look on the sides, in small children you do the doll's head maneuver, and that will tell you their movements are possible or not. So these abduction deficiency will show up if there is a sixth nerve palsy, and post-op you see they are corrected. The limitation abduction will, and you are all probably familiar with the superior oblique palsy, which will be picked up. If you can't see a child with the 3-step test, just do the 3rd step straight away. All the 3 may not be done, and if nothing else, look into the fundus. Intorsion of the extorsion of the fundus will tell you, because superior oblique does intorsion, and if you have a superior oblique palsy, you will always see an extortion in the fundus. By your indirect ophthalmoscopy itself, this will give way that there is a problem. And if there is a bilateral superior oblique palsy, always have these telltale signs: head trauma history, torsion which is subjectively complained by the child, objective torsion of more than 10 degrees, alternating hypertropia test on either side, a V pattern heterotropia, ESO in down gazes, and that is the reason why he has a chin down head posture. I say it's a bull charging, coming towards you, right? Now children may show up like synergistic divergence. Now this child is having a synergistic divergence. You see this? Now the moment he looks to that side, the abduction is much more. So this is a synergistic divergence which needs a proper therapy. This is another interesting case of synergistic innervational downshoot, the SID syndrome, SID syndrome. On attempted right adduction in the left gaze, there is a depression. It's an innervational downshoot. So you need to just check. You may observe and confirm with your testing, and these will be picked up easily, and you can do the. Now this is the post-op SID syndrome. We detected it right. We have done the inferior rectus transposition to the medial rectus, and that is corrected. So if you pick up the aberrant regeneration which is causing a problem, correction is much easier. So remember OCIPE: observe, confirm, infer, plan, and execute. So this recipe should work for all cases. Now this is a video of the same child post-op. So I will just end my talk here. Now with the nystagmus in children, the top picture is showing you a small child infant having a triangular waveform pattern, and the second, can you just, yeah, I can. Now this here, this child, you can see having a nystagmus, and if he has an adduction null, you cover this eye and it will immediately shift to the other side. So these again are picked up, and the third picture in the bottom is showing you a spasmus Newton syndrome. Now this I would like to really emphasize you people, whenever you have a child having a dissociate nystagmus, that means unequal nystagmus in the two sides, always think of spasmus Newton, especially if he has a torticollis and if he has a disjugate nystagmus. And if it is there, always do an imaging. Majority of these cases will have nothing. 80% of spasmus Newtons are benign, they will self-correct by 2 years of age, but if there is a chiasmal glioma, it will save his life. So you will always do it and you will save many children. We have come across some which we have picked up and seen. And if he has a nystagmus with the face turn, of course you can do an augmented Anderson's procedure, and you can spread sight and happiness for kids the world across, as our mission is. So thank you all for this patient listening. Thank you, Rohit, once again.
Thank you, sir, for an excellent talk. I'll now just continue from where sir has left, and we continue with nystagmus. So management of nystagmus, a quick brief on how we are going to approach such a case, and then on what would be the key management strategies. So whenever you have a child with ocular oscillations, your first question is it nystagmus? It could be many other kinds of eye movements, but a nystagmus would be... Oh, could you put the screen on? So whenever you have a child with eye movements you're not understanding, your first question is to ask, is it nystagmus? Nystagmus would be rhythmic, involuntary to and fro movements of the eye. So that is the question you need to ask. You can have all sort of eye movements, but nystagmus has to be defined by, with this. So if it's nystagmus, sorry, your next question to ask is it physiological or is it pathological? Now, physiological nystagmus would be endpoint, vestibular, optokinetic, and very occasionally very smart kids can bring about a voluntary nystagmus also, just to trouble their parents and the doctor. A physiological nystagmus is present essentially in extreme of gazes. It's essentially horizontal, won't be sustained for too long, small amplitude, symmetric in both eyes. So both eyes are going to move symmetrically, and of course there is no other pathological lesion. So when would you start suspecting a pathological nystagmus? Whenever it is not any of these, especially if there is any other neurological sign in this patient. In a pathological nystagmus, you need to know whether it's acquired or not. In fact, that's the first and the key question you need to ask in any nystagmus. An acquired nystagmus usually will present much later. A congenital or an infantile nystagmus will start presenting by 6 months of age. In a congenital or infantile nystagmus, your vision will be reduced, but in acquired, the vision will be good. The patient will complain of oscillopsia. In fact, it's going to be extremely disabling. In congenital nystagmus, the patient may occasionally notice a little bit of movements of the images, but that's just because he's being more perceptive and he's able to ignore them. An acquired nystagmus is going to be extremely disabling, and of course associated neurological symptoms would be there, like vertigo, balance issues. The other important thing to remember is if there is a latent component to the nystagmus, like an effusion maldevelopment syndrome, there is no neurological condition that's going to cause it. So you do not require a neuroimaging for that. Of course, we for ourselves used to classify as congenital sensory and motor, but essentially congenital nystagmus is grouped into one. So what is our aim of managing patients with nystagmus? We need to stabilize the eyes so that there is improvement in visual acuity, because nearer to the object of regard the eyes are moving, the quality of vision deteriorates. To decrease oscillopsia if there is, and if there is presence of a null position, you need to shift or want to shift to the primary position. This red part in the above graph is when the child with nystagmus is seeing. On any other part, either the velocity is too high for the brain to perceive the image, or the object of regard is not actually falling on the fovea. So that's the reason why the patient is not able to see. So our aim is to improve the foveation time, and you can do that by a lot of non-surgical means like optical devices. So a good quality refraction is the first step and the most powerful impact you can make. So correction of refractive error, and if required, do amblyopia therapy. if there is amblyopia, you can still give occlusion therapy even if there is latent nystagmus. It's not a contraindication, although the patient will become a little uncomfortable initially. But as the vision improves, the latent component gets suppressed, and therefore that will cause an overall increase in the quality of vision and a reduction of amblyopia, and of course overall better control of the nystagmus. Prisms can be done, base out prisms to stimulate convergence. Now, in infantile nystagmus syndrome, we know gets dampened by convergence. So you can give prisms to stimulate convergence and cause the patient to dampen the nystagmus. Also, it can help us to correct for the head posture before planning for head posture surgery. So you can induce fusional convergence by up to 7 prisms base out in front of each eye. It decreases the amplitude of nystagmus and improves visual acuity. This can be also used as a test before you plan to do surgery for the nystagmus. Important, like I said, prisms can be important also when you're measuring the amount of face turn. So the amount of face turn, grade the amount of surgery that you're wanting to do. It helps to give a predictable outcome to your surgery. There are a lot of drugs that that are there. Brinzolamide has been tried. We have found it to be moderately effective in patients who do not have a face turn. Face turn surgery, of course, is the best. Botulinum toxin has been given. It's useful in acquired nystagmus in patients with other neurological symptoms who have a known cause which cannot be operated, but for infantile nystagmus, it's not really beneficial. Contact lenses give a tactile feedback and a better quality of vision, but again, it's difficult for these patients to wear. An acupuncture study was done at RP Center under Professor Pradeep Sharma. We found that the acupuncture actually helped during the period of acupuncture, but of course was not sustained for a long term. So this is your overall what you're doing, where all your actions can happen. Good refractive correction improves the vision, which improves this feedback loop. Drugs in neurosurgery act on the control on the oculomotor system. Acupuncture and biofeedback on the effect of the oculomotor system on the extraocular muscles. And finally, to get the eyes to remain on the fixed on the target, you have Botox, prisms, and surgery. The options for surgery is to induce convergence. We talked about prisms. You can do it with bimedial recessions, and you can correct for face turn. Options for a face turn are a lot of surgical options. But at our center, as Sir said, we prefer to do the augmented Andersons, which we can do a recession of both the eyes. So our aim is to shift the gaze, the eyes away. So the medial rectus recession is done in the eye in the direction of the face turn, and the lateral rectus recession is done in the contralateral eye. I'll just show you the photographs. The advantage of this is that there are fewer side effects. It is reversible. You're just doing recessions. And of course, if you accidentally operate on a periodic alternating nystagmus, you can reverse it. You can do the other eyes, other yoke muscles also. And for residuals, you can do the yoke muscle resection. So this is how, this is one of the childs. You can see that at a right face turn, you do the lateral rectus recession here and the medial rectus recession here, and you can see the head posture correction. This is the corresponding video nystagmography of this patient, and you can see the improvement in the images. Another child with the same, you can see this is the primary gaze ENG, and this is the post-op primary gaze. Vertical recti can also be operated for chin-ups and chin-downs, and for oblique muscles, for oblique head postures, you need to operate on the oblique muscles to correct for the tilts in the head postures. Finally, you can decrease the amplitude of nystagmus in patients who do not have head posture. You have two options: the supramaximal recessions in all 4 horizontal recti. So in both the eyes, 2 horizontal recti in each, you recess them supramaximally, and the Deloso procedure. For the recessions, we do a lateral rectus recession of 12 mm and a medial rectus recession of 9 mm. This places them retroequatorially, but this is not found to be long sustained. There is a risk of consecutive exo also in these patients. And this is how it helps. It flattens the curve so that there is a longer period that is above this line, which is when the patient is actually seeing. So this is how these are supposed to help. The other alternative is the Hertel-Deloso procedure, where it's just doing tenotomy and resuture But again, we did not find any significant difference in either of the two, and maybe it's a choice which you can make. So just to tell you that now there are a lot of options for nystagmus, and really need to work up well and manage these patients which have a definite good prognosis, and we can make their lives better. Thank you for listening, and now we'll just go on to the last presentation, which is by Dr. Kaushik Murli, which is a keynote address on myopia. So he'll be talking on childhood myopia management.
Uh, Thank you, Dr. Rohit. Indeed, it's an honor to present in front of Dr. Pradeep, Dr. Suma, and Dr. Rohit, and many seniors and colleagues here. I'm here to talk about something that probably affects every one of us in this room. How do you manage childhood myopia? What is it that we know? And what is it we actually think we know and we are not too clear about? So to start off, myopia today has been defined. We've accepted the definition of the IMI, which says that it's a spherical equivalent of more than zero point 0.5 diopters when ocular accommodation is relaxed. So essentially it needs to be a cycloplegic refraction that is done. How does it matter? We know it's a significant public health problem. There have been extrapolations that by 2050 almost half our population is likely to be myopic. There is significant vision loss. A variety of ocular structures get affected, and you do end up having a number of ocular conditions secondary to advanced myopia. Do we know why it happens? Well, again, there has been this nature versus nurture debate that has been ongoing for a very long time. Parental refraction has been related to myopia progression and changes in axial length. Various genetic factors have been studied. The COMET study and all of them showed a kind of correlation with both parents being myopic, and significantly it impacted. But by and large, what we have seen is that close work again has been attributed. But today, probably we believe that it's a mix of both the parental myopia as well as the habits of the child, of pretty much the time that they're spending indoors, that probably kind of correlates and gives you some kind of an indication of what is happening. Uh, Studies have shown that children who are more academically predisposed spend a lot of time in more academically centered institution with more near work. Probably there is more myopia that is seen in them. Is it a cause effect? It is just a coincidental finding. We really don't know. The intensity of near work has been blamed. So today we end up telling children to take frequent breaks whenever they're doing near work. How much does it help the child? Again, we are not very clear about it. At least this is an intervention where we're helping them lead an active lifestyle, and that may possibly help. What we definitely know is that undercorrecting myopia does not help in slowing down progression. We definitely know that it results in educational delays, and we do know that a lot of children probably have a risk of bullying or ostracism. I'll come to this part a little later because we found some very interesting findings. So again, what we know is that unless there's no clear inhibition of slowing down from undercorrection, this definitely should not be recommended as a first choice of intervention when we know that there are much better alternatives today available to slow down the rate of myopia progression. So that is something that we clearly know. Again, do RGP lenses work? Again, bifocals have been tried. RGPs, again, we know do not really slow down progression. When you give a bifocal, this is a child at the bottom who's reading with a bifocal. What you slowly notice is she slowly started moving her head down, and she continues to see to the top part that is clear. The kid on top actually moves the book up. So most children, when they're able to see clearly on top, it defies logic to say that why are they going to see through a bifocal near ad, which is going to affect their vision. So we've not been great fans of using this as a treatment of choice. And although there are a few publications, read the literature through the lines, you see that there was a lot of bias in terms of who they enrolled and what they analyzed. So again, using bifocals today probably not a very great idea. Peripheral defocus has again come back into vogue. Orthokeratology and the DIMS lenses kind of work on this phenomenon. We know that the peripheral hyperopic defocus encourages growth in myopia, and the peripheral myopic defocus discouraged eye growth. So the orthokeratology lenses are supposed to prevent this by changing the way the surface of the cornea is. Again, you need to understand how the technology works. There are two types of lenses. You have the cornea refractive therapy lenses, which have three curves. So they don't really kind of modify. There have been studies that have looked at it saying that the peripheral flattening of the defocus isn't as great in them as with the vision shaping treatment lenses. We have about 3 ortho-K lenses currently available in India: the Euclid, the Breatho-Correct, and the GOV lenses. Of this, the Euclid lenses are the one which follow under the VST kind of a pattern. So if at all you have a choice, it's good to look at the Euclid. Problem with the Euclid is they don't give you trial lenses. So unless your parents are motivated, it's crazily expensive. It becomes a little kind of dicey in terms of what do you do. The DIMS lenses from the Hoya and Zeiss are available. Of this, when you again read through, probably the ones that are being marketed by Hoya in India work better. This is actually a blank lens. You can see those little clear area in the center through which the child sees, and you have those eyelets. The claim is that it doesn't really affect the quality of life, and physical activities are not curtailed. We don't have too much of experience with these lenses. Again, the long-term study that has recently been published shows significant slowing, and also it shows a much lesser rebound effect. Drugs have become the mainstay. We've been using atropine. The ATOM study has shown effectiveness of atropine in slowing down myopia progression. This has been validated pretty much from across the world. We today have looked at 0.01% atropine. This was a study that we published before the commercial applications were available. We showed it was safe with very minimal kind of side effect. Why this is important? You will find a segment of children who will not be responders, or who will still continue to progress. So you may need to mix up a higher concentration, and you should not be wary about it. The recent LAMP study has shown that 0.05% is good. What we know is our experience of the last 10 years, that in 10 years or in that kind of a time frame, there are no real side effect. What will happen after 50, 60 years, we have no clue, because we don't know where atropine works. Various theories are there. So today there is a choice of also playing around and seeing whether you want to use 0.01% twice a day. We have a small cohort that we are following up. Yesterday, Dr. Jitendra also presented his paper where he's shown that about 1/3 of children on twice a day 0.01% in the non-responder category actually have a slowing down of the myopia progression. So this is our data set that we've been following up now. We have almost about 600 odd children. You see two curious things. One is, of course, you see that the spherical equivalent doesn't change, but the axial length again seems to slow down significantly, but it doesn't correlate. So what are you taught when you do A scan? 1 millimeter or a 0.1 millimeter, 3 diopters of refractive error. You don't see that in these myopes. So again, what is it that is happening with atropine, where there is an axial length slowing down, but again, it doesn't seem to correlate with the refractive error? We need to pull up data. I think Dr. Rohit has started doing that, asking us to measure a lot of parameters. Hopefully, we will have some of these answers down the line. COVID has put children indoors. Again, is it the indoor work? Is it them not being in sunlight? We don't know. Again, whole lot of studies that have come out. We again have shown that children who spend more than 2 hours outdoors, there seems to be a significant slowing, especially where there's a family history of myopia. How does it work? Again, various theories abound. We don't know the intensity. Typically, parents ask us, should I send them in the morning, afternoon, evening? We say just kick them out for 90 minutes. It somehow seems to work. Theory is that dopamine works. If dopamine works, the biggest kick of dopamine the kid would get is playing his video games. Then why doesn't that slow down myopia? So we really don't know how a lot of these things work. The last thing, again, we're finding correlations is with vitamin D levels. Again, correcting vitamin D levels seems to magically somehow contribute to slowing down of the myopia progression. Again, no idea how it works, but it seems to work. We find almost 90% of children you test are vitamin D deficient. Is there a ethnic predisposition that we are not able to absorb vitamin D? We don't know. Again, we'll have to look at it. My last slide is about the mental effect. So we keep believing that there's a huge trauma. We've studied parents. We have a team of psychologists with us. They've spoken to parents. Almost 87% of them find it difficult to manage screen time. 82% of them are anxious, and 75% of them, almost 3/4, are guilty that their child develop myopia. So there is a lot of time you need to spend with the parents and actually take away the guilt from them. Children, surprisingly, we found almost 95% of them are comfortable wearing glasses. The premise is that, oh, they'll get bullied, they won't be compliant. If they can see better, you've refracted them, there's no reason why they will not wear it. But a lot of these children post-COVID are now finding it difficult to be weaned off the screen. So that is our new challenge now in how do you actually get them off these devices and playing outdoors all over again. So there are certain things we know, but there are many things we still don't know. I think it is critical for all of us in this room to look for those answers. Thank you so much for your patience here.
Thank you, Dr. Kaushik. An excellent overview of myopia and the struggle we are having now, especially post-COVID. Dr. Kaushik and many of us here were part of this consensus guidelines just released 2 days ago, and they will be distributed to everybody through the AIOS. So these guidelines will be reaching you. Of course, an online access will also be made available. So these are the recent guidelines on how to manage prevention and management of childhood myopia. But of course, this would remain continuous, as has been highlighted, that this is an ongoing research, and every year, in fact every month, we are getting newer research and newer ideas as to what's happening, because we still have a lot to know. So I think thank you everybody. We are unless there's any questions, I think we just have a couple of minutes. So anything, any comment or anything? Yes, please.
I think the Newcastle score is fair enough. It correlates with the distance stereo acuity, the study done in RPC Ames at Chirag Shigam.
Yes.
So they had compared and they see that Newcastle scoring is quite correlated. So if you don't have a distance stereo acuity, don't be disheartened. Okay, but always do near stereo acuity at least, because we don't want to reach the stage when this starts compromise. The other part was the prism therapy. Now prism, basically what you're doing is a non-surgical treatment, and it's not correcting the squint, it is only correcting the deviation. So that will be there. How long the child can keep on using the prisms also depends on how much is the deviation. So we have at the moment, if you have ground prisms, you can maximally go up to usually 14 prisms, 7 in each eye. If they already have a refractive error, that adds to the problem. So that is the limit. With Fresnel prisms, you may go up to maybe 25 or 30 prisms, but again, it causes a little bit of blurring and the vision gets compromised. So you will have to maybe think about prisms as only a deferring method, or in the time that you're waiting. I don't think it's a long-term therapy, or it's for small angle which is left after surgery. No, but prism therapy is not for exercises are working. Exercises, but not to use prisms for exercise
In
necessarily.
fact, prisms will reduce your ability, because it's going to cause fusional vergence, but at sometimes at different angles, if the prism doesn't work, because prisms will only work in straight up. If there is even a slight oblique overaction, or there is an increase in the angle in different gazes, which is not uncommon in intermittent divergent squints, then they are not going to do the work in different angles. So you need to be very sure that there is no variation in intermittent divergent squint or the magnitude of the squint. And one would say that unless it's a very small angle, a moderate angle strabismus would probably, which is, as sir has mentioned, and you can see it in a greater amount of time in small children when you can't do the Newcastle scoring directly. But if you observe a significant period of dissociation, you expect that the stereo acuity would be deteriorating, and intervention would probably be called for.
Thank you.
So So the study which we had done at our center, we found that it had encouraging results in some subset of patients, those who did not have a face turn. So presence of a face turn, your primary intervention becomes surgical correction for the face turn, because you have a documented objective increase in the visual acuity in the primary gaze. Of course, the best vision that the patient has with the face turn is what the patient is going to get in primary gaze. So that's the limit of it, but patients definitely feel better, and of course they have a better head posture. In the patients who do not have head posture and have a nystagmus, essentially none of the surgeries that we discussed really have any impact. Definitely not a long-term impact. So in a short-term study that we had done, brinzolamide was beneficial subjectively also, and objectively we found a line improvement in these patients. But all of the patients do not feel an improvement, so you can give it a try and see which subgroup of patients actually feel better with brinzolamide. So it is definitely an option, but not a consistent and a very significant impact on these patients. But yes, some of the patients were happy and were willing to continue it for a period of time. Now, endpoint, I'm not very sure, because this was not something which we continued for long. Many of the patients continue to do so, and we have patients on more than a year now. In fact, much more than a year, 2 years now. A small group of those patients we started the study on are continuing to use the drops. But not adequate have followed up for us to know whether there is a weaning off of the effect or not. Just twice a day, the commercially available brinzolamide twice a day. I'm sorry? So for myopia, homatropine or even a tropicamide, if you are able to do the timing appropriately, is adequate. On follow-up, maybe you don't even require, because you have a baseline refractive error, so you could do, you can just do the subjective testing. Of course, in esotropias, homatropine in older patients or in follow-up is possible. However, like I said, the baseline refraction must be on atropine. At least the first time you must know the baseline refractive error. No, we have not tried on those group of patients. They anyway have ocular surface issues, so I would be a little conservative in trying these medications on patients who because we really don't know how it's going to affect the ocular surface. So thank you everybody. Thank you very much for participating and for the interactive discussions that we had. Thank you very much.